All right, so we are going to talk through today about the thyroid elite profile. I have a bunch of cases in here because I know people are shy and have a tendency not to ask questions, but please ask questions. I have no problem with answering as much as I can. And if it's not appropriate in a huge group, I'm happy to send you an email or whatever so that we can touch base at that point as well. So we're going to go ahead and talk about the thyroid elite. We're going to walk through some cases. And I also thought I'd just do a little review, not a ton, right? We have limited time here, but we want to make sure that we're all talking the same language, which is actually always an issue, so that we can go through all of these different markers, know exactly how we're talking about it. You're not confused about how I'm using my language. And also where some of the controversies and where some of the differences are from lab to lab, and just even in just looking at thyroid in general. So to start through that, just a little bit about me. I've been doing hormones and lab testing and helping doctors and patients for over 20 years. I feel like I'm finally legitimate in some ways, a lot to learn still. But today, like I said, we're going to go through the different analytes, what they tell you, different patterns that you can see, and then maybe a little bit of consideration of treatments and cases, of course. So just a little bit about ZRT. We're in Portland, Oregon. For those of us who are near here, stop by sometime. We test hormones in all different body fluids, but today we are talking about blood spot serum. Most of our work, as in the elite, is a blood spot panel, and it is geared like this as a home collection. So it's geared for your patient to take this kit home and collect at the perfect time in the morning, let it dry, mail it, comes back to us, and we send the results to you. So that's how the kit is geared to be delivered. We do have people who do collect it in the doctor's offices. Obviously, that works too, but it's geared for a simple finger stick. These are the fast Lancets we use for babies' heel sticks, which you can do heels, toes, etc. Most people are doing fingers. We have instructions and collection videos for how all that works, and then they mail it up and then we send it. And then you get a report like this, which you can access through your Ruba account and download. So we're going to talk about thyroid. And the reason we're talking about thyroid is because it's a huge number of people. It's considered to be, at this point, 20 million people are on thyroid medication. So it is the number one or number two medication in the world being delivered at this point. It's about greater than 12% of the population, which is pretty huge, really, when you think about it. So women are 5 times more likely to be diagnosed than men are, but we are seeing increasing men being diagnosed. And you will also see it often in a whole line of families. And that's not uncommon to talk to a patient or diagnose a patient and find out mom had thyroid problems, dad may have, but mom had thyroid problems, grandma had thyroid problems, even great grandma may have had thyroid problems. So that's something that you can see much more commonly now. And partially that's because we have medications. We can treat people now that allows their fertility to come to a normal level so they can have children, and unfortunately maybe pass along risk factors. But there is likely also environmental issues, triggers that are also part of this equation. And we know, unfortunately, that animals, wild animals, our pets are also seeing an increase in thyroid disorders as well. So this isn't just something that stays with humans, sadly, but today that's what we're talking about. So lots of women getting it. And when we look at our profile, ZRT actually has 3 different profiles. You have a sort of the initial, but we're going to talk about the elite. So it's TSH, free T4, free T3, thyroid antibodies, total T4, and thyroglobulin. Let's talk about what all of those things get you. If you want to go one step more, and I think I do have a couple of slides that I may have this information where iodine and selenium as part of the elements were also in there, but that's technically another kit. But sometimes the labs were too good. I had to share. So TSH as a marker is one of the oldest tests that we have available. Some people are really surprised to know that it's still not that old. It's, at this point, I think it was developed in like the 40s for commercial usage. Before that, if people had high cholesterol, they were put on thyroid medication, Or if they just had symptoms of thyroid, they were put on thyroid medication. If you looked like you had it, they just treated you for it. So it is a lab that has a national standard. So one thing that always comes up is blood spot. How accurate is blood spot versus a serum draw? We do blood spots for TSHs all the time. Every baby that's born does a infant PKU test. Part of that PKU panel is a whole bunch of other things, including thyroid markers. So TSH markers for babies have been developed for since the early 50s. We're just taking it from babies land into big babies who don't like blood draws or people who live rurally or all the other ways that you might want to use a thyroid test. It's a national standard, which means that a one should be a one, should be a one, a two should be two. There can be variations, slight, but they shouldn't be dramatic. Okay. But there is big controversy regarding the ranges. And that's where you'll see a lot of differences amongst labs and amongst even interpreting of it. So I wanted to just touch base on that a little bit. That controversy has been raging for probably 20 years, as long as I've been in practice. And I don't quite understand it. At this point, most of the endocrine societies have recommended that the ranges should be tighter. Most of the fertility docs want a tighter range. Most of the thyroid specialists have asked for a tighter range. The laboratorians have asked for a tighter range. And yet most labs do not have a tighter range. The reason comes from this being an older test. And when tests are older, there's a lot more variation in how sensitive your testing is, right? You can't tell maybe the difference between a 1 and a 4. So you have to make both of them normal if you're going to run that sample 100 times, and there could be that much variation. That's not where this test is at this point. This test is pretty precise, pretty reproducible. And so, yeah, there may be some variations, but it's not at the level it is. And when we look at population studies, and this was done with 65,000 people, the Australian Thyroid Association had this slide. I just love it. But this has actually been reproduced in trials and data where they've done tens of thousands of people all over the world showing the same TSH distribution. Really, you can see that after 2.5, which no surprise is the clinical knockoff for fertility, we're seeing most of the people. That's where most people are. This is not a bell curve where the middle of the range is where most people are. This is a bell curve where most people are between 1 to 1.5. So after 3, you get very few people who don't have thyroid symptoms, who don't have high cholesterol, who don't have other markers of thyroid problems. And once again, they've done this study over and over again. I don't know, when I asked my local Quest doc, hey, when do you think Quest might change their ranges? They told me when everyone agrees. So you guys can guess as much as I am when that's going to happen. But that's controversy wise. For ZRT, we have changed our ranges. Our ranges are tight. You're going to see us present down to where the laboratorians and endocrine societies are saying is where we should be. A lot of labs have slid their ranges. They used to be 5.5 years ago. You'll see a lot of labs have changed it to 4.3. I think you can go tighter than that. We could talk about TSH for hours. We won't. Keep in mind that anything over 3 in any lab is going to be problematic. So why are we seeing so much else? I did have someone who was kind enough to put in a question before this presented. So I did want to just put this in there, which is our role in our active use now of genetic testing has really given us maybe a little bit of an eye opener for the genetics. So these are the markers that are now really being looked at for hypothyroidism. And the first marker that you see there, that's actually thought to be like a 20% increase in genetic family risk of thyroid disorders. So I think we will see many more of this. We are seeing genetics as far as TSH receptors, feedback for TSH. So I think we are just at the hint of this being very much a family hereditary thing for lots of people and trying to figure out where is it? And clinically, does that give them a different picture, even if their labs are normal? And does that give them a different picture when their labs are abnormal as to what we need to do to help them the best? So very much a work in progress, but I'm excited to see where that comes from. So we want, besides TSH, we can also measure the end product of the thyroid gland itself. So those are going to be our total T4s and our T3, and our free T3. In older labs, you'll see things like T3 reuptake. And I still see like a lot of hospital labs will throw that in there. That was an indirect way when the T3 couldn't be tested directly. It's one of the newest tests. So it doesn't have a huge long history. And as a result, that's why you see all these sort of other ways of testing it. But now that we can test it directly, I don't think that there's any reason to not test it that way. When we look through some cases, I'll show you where I see people's levels being, because I do hear, and I want to talk about like lower T3s a little bit, because you'll see a lot of people who will lecture suggesting that people should be at the upper 1/3 for most of their thyroids. And I would disagree with that. I find that most people who have really good thyroid function actually are at the bottom of these ranges for T4 and T3. Doesn't mean they're not getting effective. I think really what it is that they actually are. They have very clean receptor sites. And as a result, they just don't have to make a lot in order to get good activity. So we'll look at that. But most of your thyroid is going to exist as T4 because that is going to keep it around longer. It's going to be able to get everywhere, right? You're going to be able to go ahead and get that thyroid to your brain. You're also going to get that thyroid to your big toe. You're also going to get that thyroid to your heart. And you're going to have a 7-day half-life with T4. T3 is very fast. It's going to be there and back. And if you've ever taken T3 directly, your heart has a lot of T3 receptors. It's going to get its share. Your brain's going to get its share. But your big toe, your ovaries, those might not get as much with just T3. And its half-life is very short. So it's out. It's only going to be in there hours. It's a cherry on the top of the cake. Everything has to be turned into T3 at the cellular level, but that T4 is there to be this reservoir of active thyroid as you need it. Total T4 is bound and unbound. There are some really interesting patterns that you can see with looking at total values as well as just free levels. So I made sure I pulled a few of those. I think that if you had to choose, obviously we would just choose our free T4 and free T3. But I think when you have someone where they have many more clinical pictures of oddness thyroid-wise, you're going to want to go ahead and maybe pull those T4s as well as totals. The thyroid is pituitary. It's asking the thyroid gland to make T4 and T3. That T4 is converting into T3 and then being fed back. And that whole pattern takes years to be developed. When we are growing up, when you're little, you're developing these patterns of TSH converting, right? And as a result, your TSH levels can be allowed to be quite a bit higher. But it is amazing. By 16, 17, your TSH really should be where it is. And even younger, you'll see some kids will take a little bit longer. It's okay to watch them. Sometimes their TSHs will be higher, and the ranges I was showing for you were adult ranges. But kids are allowed to have a broader range, and then they should shrink back down. Still, if you look at the data, by probably about 10, most kids are within the adult ranges. So if you watch them, I think that's where you get into the clinical piece of things, because I certainly have seen kids where, yeah, they're within the normal range for kids, but parents have thyroid problems and they're having symptoms. And we can watch and wait, which is absolutely one option, or we treat the patient. So that one's a little trickier. For kids, just because I see someone mention it, and I think this lends itself to kids so well because you don't have to poke them, right? You can poke their finger or their toe and get these levels. With kids, we put ranges in specially for them. So you do want to make sure that you are looking at kids' ranges for those. So we can have problems with thyroid anywhere of places of these, right? Because it even comes more complicated. The pituitary is also taking T4 and converting it into T3 with completely different non-nutrient dependent pathways. it is possible for your brain to be perfectly happy and your body to be perfectly miserable. We could talk thyroid for days, but I want to get on to cases. So I'm just going to move a little along faster so we can get everyone's questions answered. Autoimmune thyroiditis is, I think, very much being recognized as a big problem for thyroid. Having triggers of viral infections certainly can go ahead and cause inflammation and autoimmunity. It is often a cross reaction immunity. So oftentimes you're triggering immune system activity in the GI system. And it just so happens the thyroid gland embryologically is coming from the same tissue as the GI. So you cross react and you're now getting thyroid problems, whereas before your body was fighting H. pylori or Giardia or something else. Okay. So that's where you see that kind of cross reaction happening. People who have high antibodies, even in the presence of normal thyroid function tests, in other words, TSH, T4, T3, are more symptomatic because this is low level inflammation. This is the thyroid not working properly to put together thyroid, even though the labs might look okay. So we'll see these, but a lot of these people are going to fit into the terminology that we have of like functional hypothyroidism. And we're going to talk hypothyroid mostly because that's the majority of what you're going to see. Okay. Now, thyroglobulin, when I'm talking about thyroglobulin, I am talking about thyroglobulin. This does have antibodies as well, and those are called thyroglobulin antibodies. But thyroglobulin itself is basically part of the mechanism to make T4 and T3. And it's really interesting. It is a tumor marker. So a lot of the research you'll find on it is used commonly for people who've had their thyroids removed because it's made by thyroid glandular tissue. If you've had your thyroid removed because of cancer and all of a sudden you start showing up as having thyroglobulin, then somewhere in your body there is thyroid tissue doing its job. So that's why, thankfully, this marker has been developed because now we don't have to torture thyroid patients by making them miserable. And we used to have them go off meds for a long time and it's terrible. So now they can use this, but it is part of the mechanism of making T4 and T3. And it's one a lot of people are less familiar with. So I just wanted to give you a couple of other markers with it. And just one is to show a picture. And I think, sorry, let me just click here and make sure we got this on here. Whoops, gonna go back. So at the bottom of this slide, what you're seeing is the blood, okay? And at the top of the slide here, you should see where the colloid is. So that's like the center of the follicles. And then there's these columnar cells all the way around that are part of the wheeling and dealing between TSH, getting things into the thyroid, making thyroid and storing. If you think about it, the thyroid gland is one of the few glands that stores hormones for months. It has about 3 months worth of hormones that are sitting there. So your body has to have a way to have this very active hormone sitting there. And actually throughout its whole process, it does this hand holding it. So it's not doing what thyroid does, which is increase metabolism. That doesn't work. We've got to really control when it's used and when it's not used. So thyroglobulin is part of that. And it's basically taking iodine and tyrosine and linking these up and then linking up more of them. And I found a really great video when I was looking at this that I wanted to share. And you can see the link down below, but I thought this man did a really nice job of just talking about like how thyroid's made. But you can see like this big tangled mass of knitting. Did I just unshare my slides? Hopefully I didn't. Brittany, yell if I did.
I can see them. You're good. Yeah.
Okay, good. Okay. So what you can see here is this big tangled web. And you can see like T4 is attached to it and T3 is attached to it, but it's also T2 and there's T1. They're all just hanging on to this molecule. And then when TSH comes in, it basically says, hey, we need thyroid. And then this whole structure gets basically morphed into those metabolic cells and the columnar cells and broken apart and then attached to thyroglobulin to go off into the world. So I thought this gentleman did a really nice job of really walking through in a very short little video about how thyroid's made, because it is a multi-step process and it's very active with like cyclic AMP, and it's made in the Golgi body and the endoplasmic reticulum, which I'm so obsessed with. So all of these things are getting activated and used in it. And I think this is where we're going to find, that there's going to be problems for some people in these different sections. So that's to come. It'll be interesting to see, but I have no doubt we'll find that there's some genetic variances for some people that are in this process as well. So elevated thyroglobulin, if people are new at looking at that one, it is part of that collagen and colloid matrix, right? So anytime the thyroid's enlarged, goiter, nodules, anytime there's inflammation like thyroiditis, and then hyperthyroidism, and then thyroid cancer after treatments, those are all reasons that you can see it be high. So just as a reminder, just because we're talking labs, just us doctors and healthcare professionals, if we see weirdness, do ultrasounds, have a look in there. It doesn't cost patients a lot of money. It's good to just have a measurement. Worst case scenario, it comes back normal. That's a great thing. But thyroid cancer is one of the cancers that's actually on the rise when everything else is being decreased, unfortunately. So we do need to make sure we're keeping it in our back pocket idea. And in women, it's really been increasing in women. And it is oftentimes a cancer that shows up in the 30s. So just be a little suspicious if you see weirdness. All right, so let's define what we're talking about when we talk about low thyroid. The classic or frank hypothyroidism, overt, is the classic TSH is high, T4, T3 are low, and the patient has symptoms. Subclinical hypothyroidism is going to be a lot of our patients. The TSH is high, but T4 and T3 are normal, and that's free T4, free T3. And then, but symptoms are reported. And then functional hypothyroidism, where all the labs are normal, but the patient complains of symptoms. Now, I think it's important for us to just take 2 seconds and acknowledge that if you've got a lab that's still reporting ranges of normal up to 5, our definition of subclinical and functional might depend on how we're viewing those ranges. But there's a lot of debate of, do you treat people who are subclinical or not? My big criticism with a lot of those articles is that, and experiments and research, is they don't treat adequately. They don't treat to drop TSHs to less than 2. They treat to get them within the range for TSH. But unless you're getting that TSH under 2, even sometimes down to 1, a lot of patients with thyroid are still clinically symptomatic until you get to that point. So that's been my big frustration with the subclinical debate as to whether you treat them or not, is you're just not treating. It has to be done to a certain point. Otherwise, we're really not adequately treating them. All right, let's look at some labs. Now, Brittany, should I look through some of these questions first before I go on, or should I not?
I was going to say that we do have one case study sent in through the Q&A if you want to look at that. Yeah, if you want to look at that, and then we can tie in all the questions for the part. Sound good?
Absolutely. Sounds
Great.
good. One of the questions that we have was a 7-month-old postpartum woman who has amenorrhea and low TSH, low normal total T4, low T4, and low T3. So just with that, just knowing that, 2 things should come to mind. Low TSH, low T4, and low T3 after pregnancy. One of the things that you can see is pituitary damage. And you'll see it because of profound bleeding, so hemorrhages, or intense pushing phases in delivery. So Sheehan syndrome is the classic empty sella syndrome. So you can have basically the pituitary just go offline completely. That is a factor that can happen after pregnancy. And it can be all of the hormones. So you'll also get low LH, FSH, TSH, adrenal, like the whole thing can go off. Or you can just see some of the pituitary functions be decreased. So this person also said, though, that they had antibodies, and postpartum thyroiditis is common. In this situation, she was saying clinical thyroid stimulating immunoglobulins. So in this situation, it looks like she may be, let's see here, below standard. So T3 and T4 are low, but the thyroid stimulating antibodies are high. Interesting. Usually that will give you a hyperthyroid situation. And it looks like she hasn't had a period, even though she stopped breastfeeding after a month. So I think that's definitely not normal. 7 months after delivery, 6 months after delivery, and no breastfeeding and no periods is definitely abnormal. And I would say they should definitely be worked up. You could follow thyroid serially, but low T4, low T3, a low TSH, I would definitely be checking LH, FSH, and prolactin just to see what was going on there, and maybe even some imaging as well, so that we can rule out that there's no pituitary problems and just have a look as well. So just a couple of questions. I just want to have just a little bit of glance here. And let's see here. Sorry, I'm going to double check it. So I want to make sure I answer all questions. So reverse T3 is a question that I get asked a lot. There is very little hormone in a blood spot. So the problem with reverse T3 is there's very little of it there. Anyways, when you get to a blood spot, it's a little bit of a volume, but it's also the levels of detection. So right now, the way you have to do reverse T3 mostly is radioactive immunoassays, which we don't do, or you can do it by some LCMS. It's very little is in there. I don't know whether we'll develop it. It's definitely a question we get asked a lot. And I have lots of varied uses, but or opinions and thoughts about reverse T3 clinically, how useful is it versus not. But I know that many providers have found it useful. If that T3 isn't going to active free T3, then the thought is it's going to reverse T3. And when does it do this? How much does it do this? How stressed? What does the system have to be like in order to cause that to happen long term? I think that's where a lot of the discussion is actually. But that's the deal with reverse T3. It is a technologically laboratory challenge to do at this time. Doesn't say it's not going to, but that's where it is. Total T3s, as far as using total T3s, they can be useful. Generally, they're mostly useful if you're working someone up for thyroid, like hyperthyroid cases. So that's when you do everything at those cases. All right, let's look at some cases. I got some labs for you. Let's see. All right, so this is what ZRT, we'll just do a little orientation here for people who are not used to seeing it. So we have the sliders, the results are within the sliders, and then you can see the ranges to the right as well. Most of these, like I said, are actually laboratory standards, national standard, except TPO antibodies. Those are not nationally standardized. There are, the way these work is we buy a kit from a manufacturer that we use to process those labs. There are about 4 different kit manufacturers for thyroid peroxidase antibodies. So you will see that those ranges will vary. There'll be ranges out there. I've seen them 0 to 2. I've seen them 0 to 9. I've seen them 0 to 50. So those TPO antibodies can have a pretty broad number. So you really have to look at your number in relationship to the ranges that you're seeing. And I do think one of the nice things with ours is that these antibodies are not just positive, negative, right? It's a spectrum. So normally they should have pretty low levels. They should be really like less than 10, but you'll see them gradually increase. A true positive is going to be 150. We've seen them in the thousands, right? But you'll see it as a rise over a spectrum of time with these. That's harder to see if your ranges are super tight and you're using an assay that just has a range of 0 to 2 or 0 to 9. So clinically, I like that because someone who's normal at 140, 130 may be more symptomatic than someone who has a level of 10. So that's how it is. But this is the case that is really common. And I think this person would show up in most people's practice and they'd go, oh yeah, this is subclinical hypothyroidism. We've got a high TSH. We've got normal T4s, normal T3s, right? And negative antibodies. And this is someone whose thyroid isn't working well. I think most people would catch that. I have seen it missed. I have seen people say, oh, you're fine, because sometimes more testing confuses people. If your TSH is high, that says your brain's not happy with how much thyroid's being produced. And so having a high TSH, even though your T4 and T3 is normal, isn't normal. It says your brain is shouting out for thyroid. And it is a rare patient who may have a level like this who doesn't have symptoms. So usually what you'll find is that you go ahead and you need to do, you treat these patients and you get those levels down and they feel much, much better. And a lot of times this is a slow, gradual thing. So you can go back and look several years sometimes, and you can see this TSH that's been creeping up over time. But these people, most people are going to, like I said, are going to diagnose them, especially if they've just done the TSH. But don't get confused. A normal T4, normal T3, and a high TSH is a problem for 99% of people. And if it's not, make sure you're really looking at things like cholesterol, blood sugar. It's not always just fatigue symptoms. So classic. All right, but look at this one. This one's a little interesting, right? So this one is a typical one that I see where we have T4, T3 is normal, but look, the total T4 is low and the TSH is high. Now, TSH is only high because we have a tightened range down to 3. But this is definitely someone who would easily get missed in most practices if they're not into functional thyroid, right? These are the people that are so happy they found their way into your offices because you're willing to give them a trial of thyroid. A trial is not going to make their thyroid never work again. Okay. You can do that. Can you do with supplements for these people? Yes. These people that are in this less than 4 period of time, you can often do well with some supplements, and that may be all they need. But some people are going to be really symptomatic and are going to be better served with medication. So you've got lots of different options. And I think it's interesting that in this person, the total T4 actually showed the low, but they were changing how they bound that, right? To make sure that they keep that T4 normal as long as possible. I have seen people with normal T4s and T3s where their TSHs were 12. I didn't manage to find one of them to pull for this presentation, but I have seen that. So high TSHs, normal T4, T3, doesn't matter, okay? They all tell you different things. So this is another subclinical hypothyroidism. Now, how about this person? This is an interesting one. This is one that you and I often see because these are people, their thyroid's fine. You do have these numbers. That total T4 looks great. That free T4, that T3, all looks great. The TSH looks great. But look at the antibodies and then look at that thyroglobulin. That's really high, right? What's happening here? Autoimmune thyroiditis? Absolutely, because their antibodies are high. That thyroid's getting larger. There may be a lot of colloid production and a lot of stored thyroid happening in that thing. So we might have a nodule as well. We may have goiter, but autoimmune thyroiditis definitely can present just like this. These people will be terribly symptomatic. They can be. They can also not know. It's amazing. But they can have hot flashes. They can have night sweats. They can be fluctuating their thyroid from day to day because every time their thyroid is damaged, they could potentially be releasing 3 months worth of thyroid at one time. So you're going to see these people, but you're not going to see it if you don't look for it, which is why we like to test those antibodies. I did see in there a question, and I will make sure I answer all questions, just maybe not live here, but a TPO antibody that's high. Thyroid globulin antibodies are much less common. So a thyroid peroxidase antibody will show up for over 90% of autoimmune thyroiditis. They can have that plus thyroglobulin as well. It is a rare person who has thyroglobulin antibodies without having thyroid peroxidase antibodies at the same time. I certainly would wonder if this person also had thyroglobulin antibodies. Probably. I think the whole thing is just a mess. That's why I enjoy thyroid so much, because it's messy. All right. So here's another case. And I specifically wanted to pull this one because it shows a really common scenario I get a lot of questions on. So here's someone, right? Thyroglobulin within range, total T4 lower, T4 upper end of things. the T3 is low normal, the TSH is normal, and the thyroid peroxidase is normal. So I think this one's a really interesting one because I often get asked, what do I do? Or why is this T3 low? What does that mean? It means that at the time of testing, they didn't have a lot of T3 being manufactured. And is that the conversion between T4 and T3? Could be. But there are lots of other reasons that you will drop your T3. And where are you putting it? You're going to put it into reverse T3, right? But there's lots of other reasons. Low calorie diets, low carb diets, being sick. So viral infections, colds, infections, anything that kind of really stresses the body, you can drop that T3. If the TSH is under 2, it is unlikely to be a persistent problem in my experience. Usually when I've seen those T3s be low and that person has a ton of symptoms, you'll see TSH crossing usually over 2.5. May not be dramatic, but those are the people I usually see have this T3 being low at a routine level. Okay. Is it worth doing T3 testing if someone's in a hospital? No, they're going to be low. It's stressful. Something bad's happening. Okay. So make sure you really know what's happening with the patient. But I'd say, what if you've got someone who's doing Ozempic, right? What if you have someone who's doing a big weight loss diet? Are they going to drop their T3? If they're dropping their carbs and dropping their calories, they may be. So maybe instead of doing thyroid hormone, maybe we should just be working on like just improving the stress response, looking at calorie diets, looking at metabolism and cortisol and adrenal support. But in this person, I think it's interesting because she'd come off of her thyroid 2 weeks ago. And I think that's important too, because the timing of people using their medications definitely plays a role in this. And my guess is everything's going to start going off for her. It's just 2 weeks. You still have a lot of T4 to start playing with. But I think that free T4 is also going to drop. Her TSH is going to go up. It's just going to take a while. You have to give it 4 to 6 weeks for letting thyroid normalize and work through all of its total values and it's bound up and everything. So that's a fun one. I only have a few others, and then I want to make sure I get through everyone's questions. But this is another question, right, of looking at those T4s, those lower T3s, and those higher TSHs. So you'll see this pattern a lot. And I really am a little bit more cautious about just jumping on board and be like, I have to give them T3. I just find a lot of times it's really more an adrenal issue or a nutrients or some other cause. But it's definitely something to like really ask a lot of questions for because it doesn't happen. It just isn't necessarily the first thing you should go to. It should be something maybe that you circle back around to after you've ruled everything else out. T3s are helpful, but once again, newer tests, and you could track these over time and you can see what this person's doing. T3s being low, just be really cautious. And if you're using T3 for supplementation, which we'll talk just briefly about supplements and nutrients right now and thyroid medications, if you're using for T3, just know it's very suppressive on your TSH. So you're going to see labs when you use T3. You just have to really know what that person's doing, how routine they've been about taking it, and make sure you're trying to compare apples to apples when you do it. So I went ahead and just pulled some thyroid medications. Like I said, 20 million people are on thyroid. If they changed the ranges and dropped it down, that would add millions more people. So I don't know, maybe if that's a factor as to why it hasn't. Sometimes when things are really common, people start thinking that it's just the new normal rather than the shifting baseline of, oh, maybe this is now normal for us, rather than something else is a problem. And we better figure out what it is. But you basically have your T4s and your desiccated thyroids. Just a heads up with some of them that's nice to know. Tyrosint, if you're not familiar, that's a newer one. It's been out for a while, but insurance doesn't like to pay for things. A new thyroid on the block is harder. Tyrosint is in a gel cap. It's a liquid, so you can actually get it as a liquid or as a capsule. in a liquid. It is really nice for people who have GI issues because absorption is basically 100%, or people who are non-compliant or have to do medications that may interfere with absorption. Tyrosine has been shown to be helpful, even if they're eating, even if they're taking anything else. And it also comes in a liquid for kids who can't swallow pills, which is nice too. Doesn't taste like anything. You can chew all of them, but some of them are not as tasty as others. Thyroid is all bioidentical. It all works. When you bring in your desiccated, you're combining T4 and T3 together, but you're also going to have sort of the beastie bits of thyroid. So you're going to have the T1s, the T2s, and the glandular pieces. Pros and cons for all of this. As someone who's watched thyroid, I personally am a thyroid patient. I've used pretty much everything you have on this list. Compounding is another option. I didn't put it in there because it's just putting T4s and T3s together. I will tell you that fillers are a huge deal, that some of the generic medications have much more variability pill to pill than we would want them to have. And some patients are going to feel that more than others. And then when it comes to the desiccated thyroids, they're different from how they used to be. 20 years ago, the T4 and T3 was pretty even, and you saw the average dosage that most people were using was 1 grain or 60 milligrams. Now, I would say the average dosage is 1.5 grains. And so 90 milligrams is much more common. And the T4, T3 levels, it seems like some of these are keeping a lot more T3 and not having as much T4 in them. Now, these companies do a good job. They have to test their products, but I don't know whether there's something in there that's binding and not releasing it. But just be suspicious, right? I'm going to see the problem people. But if you've got someone where their T4s are not really in the normal range, their T3s are really at the higher end, just know that I've seen with different fillers and binders that sometimes T4 seems to be the problem child in that. So you can always separate the T4 and T3 out and work around that. In general, you're going to find your patient, test them, start with a therapy, and then reevaluate. Let's go through some questions. Is that okay, Brittany?
Absolutely. Let's do it. I'm happy to moderate these questions for you, but I know sometimes it does go faster for the expert to just go through. So I am good to do whatever you want to do.
All right. I'll go through the questions. Yeah. And then you can, if you see something that I'm missing, maybe in the chats, feel free to. How about you do the chats and I'll look at the questions?
Sounds good.
So I had a question about reliability with blood spot versus serum. Blood spot's super reliable, like I said, but we are dependent on the quality of the spots that we have. So it is important that people do read the instructions. It is important that they just give us single spots, but we should see the same. Now, one thing that I've definitely found that is a big heads up, and this goes across all hormone testing in general, and it doesn't impact all of ours, some more than others, but just get in the habit, biotin. So a lot of patients with thyroid are on biotin. They're on hair and nails formulas. They're on high dose biotin for hair loss. Biotin is a problem for hormone testing. Now, it isn't as much of a problem for ZRT, for our LCMS tests or our saliva testing, but just get in the habit of not doing that. So I have seen cases where ZRT has a different TSH than what they've done at Quest or LabCorp, for instance, but the patient was using high dose biotin and the LabCorp Quest lab has an issue with that and ours didn't. So just get in the habit, biotin off of it 5 days before you do any serum testing. Labs are definitely finally getting into this, but I don't know if it's trickling down as much into those of us who are telling patients what to do. So be aware, anything in the hair nails over 1 milligram, they need to be off it. Multivitamin is fine. So the genetic SNPs, is that going to cause high or low? The genetic SNPs are thought mostly to cause hypothyroidism. So that would be a high TSH. So it's an increased likelihood. I think there are other SNPs that have other variants with TSH receptors. So we are seeing receptor variability, but the links for those SNPs seem to be linked more with just an increased risk of hypothyroidism and high TSH. Questions of the low T3. I think I went through that one, but the question was like, could that be genetics? Could that be nutrition? It absolutely could be nutrition. Selenium is needed to convert T4 to T3. So if you're missing selenium, zinc, iron, all of those are going to impact your thyroid, and your brain doesn't use those nutrients. So it's using a different deiodinase than the rest of your body is. So yes, potentially, but I don't know if the genetics are part of that T3. Probably. So antibodies aren't an issue. The antibodies, I had a question of like antibodies in serum versus antibodies in blood spot. When you are doing antibodies, they can cling to, if you're doing a serum separator tube, they can cling to the gel in there. So that's why they ask you to separate those out for the best levels. In blood spot, it's not an issue. There's no gel in there. So that's not been an issue. Someone had a question that they themselves have been on T4 and T3, but still have a TSH of 4.9. I think that is pretty common. And the question is that good? Not usually. Usually people have problems with symptoms, and that would tell you you need more thyroid. If you're on a pretty good dosage and you're still seeing TSHs be 4.9, and you're like, but I'm on thyroid, I'm on maybe 150 of T4 therapy, I don't understand. It's probably the fillers. The fillers and binders are a big deal with thyroid. If you switch just from one brand to another, 80% of people are going to be fine, but 20% of people, they're going to drop their thyroid or get too much. It's going to be different. So change it up. And if there's ever a question, like go to Tyrosine. Insurance hates to pay for it, but they have a program on their website. I don't work for Tyrosine, but go to their website. You can find like pharmacies they have deals with. It's not terrible. It's basically the same price as a copay for most people if they have any insurance at all. If you don't, there's other ways that you can get it. Mark Cuban's pharmacy has started dealing with it for people. So sometimes you just have to take those fillers out. My bariatric patients, I put them on that all the time. They just don't absorb as well through their stomach. So people with GI issues is definitely an issue. Where do I think you should aim for TSHs with being on medication? I like that TSH to be where most people's TSH is, which is 1 to 1.5. There are going to be people with antibodies. Sometimes you can get down below that 1 before they finally feel okay. And that's going to be much more likely when you're using T3 therapy. But if you've got someone on a T4, like you really want it to be down at that 1 to 1.5 range. And that's, like I said, my biggest criticism with a lot of the subclinical hypothyroidism treat or not treat articles. They don't aim to drop TSH that low. They just aim to get it within the normal range, which for many people, that range is up to 5. So if I saw someone come in with 5, I would start them on thyroid. So if I have someone with low thyroid and their TSH is 5, to me, that's not treating that. And that's where I find a lot of those articles and research to be such a loss. Because if we treated people down to 2, what would we see be different versus not treating them? So maybe someone here is listening and is a researcher. Please do treatments with goal TSH levels. Someone questioned what were the previous ways of measuring T3? They didn't used to really do it. But the one that I remember learning in school and having a very long, complicated story to try to remember was an inverse relationship with reverse reuptake T3 or T3 reuptake. And it was basically trying to measure the opposite of what T3 wasn't taking place with. So that's definitely a factor. I don't think it's that good and that useful, but I still see it out there because I think it's cheap at this point. Someone had a question about thyroid medication and day of testing. That is a great question. So in general, thyroid TSHs are highest in the morning. So you do ideally aim for a before 11 o'clock a.m. testing. And I generally will have my patients not take their thyroid that morning, especially if they're on T3, just so that I can really see where their T4, T3 levels are in TSHs. And I don't have any questions about that. And that usually works just fine. I have tested on the day of testing if they're taking thyroid, but if they're on T4, it's fine. You can take it anytime, no problem. If they're on T3 and they took it that morning, bring them back in, do it at least 6 hours later. And like I said, the beauty of a blood spot is they can just do it before they take it in the morning, and they're not even going to skip that day's dose. They can do both of them before they go off to work. So it makes it super easy to do it. But T3, some people aim for doing that 6 hours to see how much T3 is still active if they're taking supplementation. There was a question of, is there a correlation between thyroglobulin and TPO and thyroglobulin antibodies? If you have, like I said, thyroglobulin is going to be more like the colloid impact. But if you have high TPO antibodies and you have high thyroglobulin antibodies, odds are that is the person that may also have thyroglobulin antibodies as well. But they could just have a lot of raging inflammation too and colloid production. It's not a clear cut 100% for sure. Let's see. Someone asked a question of how about low normal T4s, low T3s, and low TSHs, but doesn't do well on cofactors and has symptoms. Sorry, just move me here. Symptoms of high and low, and then has adrenal issues. If you have low T4 and then normal T4 and normal T3, that's definitely a question for, do you have antibodies happening? If you have really low TSH and then like low normal T4, like less than 1, and low T3, like that's a sign more of pituitary problems that may be happening. And the body's going to pull in a lot of other things to try to compensate. So I can imagine you could have lots of different symptoms, but that's going to be pretty rare. But you have to rule out some of the pituitary issues that may be going on for that situations. You might they had a question of, should you, in maybe that case, do things like thyroid stimulating immunoglobulins? Yes, in those cases, you might be looking at like a Graves, you might look at thyroid stimulating antibodies. There's a whole list of other antibodies, but they're not the most common that you will see, of course. Can people do this testing from Canada or internationally? You can. This blood spot testing can be done anywhere. We have people shipping kits from around the world. Is there a good way of looking at iodine levels as an addition? Yes, you can do iodine in blood spots with the same test. You can also do iodine in urine. Usually urine is the best. We do 2 urine strips and it's equivalent to a 24-hour iodine level, And that's an easy test for people to collect. And you just get the equivalent of a 24-hour iodine level. And iodine is a growing concern. It's low in a significant number of people. The thyroid people are concerned with how low iodine is. And that's because a lot of our processed food, although it has salt, a lot of the companies don't use iodized salt. So that can be an issue. And of course, our food comes from all over the world. So selenium nutrients in our ground, it may be fine in our backyard, but it may not be fine in Colombia where we're getting that food from. Randomly just chose that. We do need to look at all of these things, and nutrients we know in general are struggling in our food, even with the same food. Let me see. We have a question here about a patient who is 33 years old, female, who had a lot of stressors, had an abortion 6 months ago with a lot of weight gain, GI issues, headaches. Sounds like a lot of thyroid, lots of family history. And then she has a high thyroglobulin. So something's happening there, right? She has a total T4 and T3 that are normal. T3 is normal. Her TSH is 6 and her thyroid antibodies are negative. That's someone, because of the thyroglobulin, we might do an ultrasound, but with a TSH of 6, that is someone who is hypothyroid and probably should start on medications at that point. Could that be because of the stress of pregnancy and then loss of pregnancy and postpartum thyroiditis? Absolutely. You don't have to complete pregnancy in order to get your immune system to be different. So it could be the immune situation and it's going to be transient, or it could be something where it was a straw that broke the thyroid's back, so to speak. And then that's an issue for that. And a question on iodine consumption. I think we want to be more moderate. The thyroid doesn't need much iodine, 150 micrograms. And the more deficient someone is, that's the aim of where you want to start. But that's a little bit of a whole other topic. So I'm going to skip that, but there's definitely kind of ways that sometimes you might want to do more. Someone who had a TSH of 3.9, but once again, those normal T4s, normal T3s, remember, if the thyroid, the TSH tells you how happy the brain is. If the brain's not happy, doesn't matter. The body will keep T4 and T3 normal as long as possible. And you'll see it in the total T4s, but you want their TSH ideally to be within those levels. Most fertility patients do want their levels under 2.5. Someone mentioned that for fertility. Absolutely. Once you cross 2.5, the rates of miscarriages, the rates of infertility dramatically increase. So that is definitely something that there are different ranges within there, which is, to me, if you can't get pregnant at 2.5, why is 4 considered normal? Right? This may be different if you've got someone who's chronically ill. You may think of a different, right? Different levels might be okay for them. Someone who's 80, you might be okay with them being a little on the higher side. But if you've got a 30-year-old who couldn't get pregnant if their TSH or had a 16% increase in miscarriages once that T3 or TSH crosses 2.5, why is it okay for them to have a level of 5? It's just not. I think it's just a lack of togetherness with the endocrine societies to basically push the labs to change it. I don't know why. Seems like cholesterol labs get changed like that. Let's see if there's anything else here that makes sense. Does thyroid antibodies correspond to dysfunction? It does. So antibodies are ripping apart the thyroid, essentially. It's basically gumming up the whole system. So it's also creating a lot of inflammatory cytokines. So you've got thyroids releasing huge amounts at sometimes and then nothing at all. And you also have people where they're just creating all this inflammation. So people are the system isn't working as well when thyroid peroxidase is a problem. We definitely want to make sure that we're treating people with high TPOs, even if everything else is normal. Like there's an inflammatory thyroid process. They may or may not go on to have classic hypothyroid symptoms or classic hypothyroidism. But if we can reduce inflammation in the thyroid, then we can try to change that. Clinically, they're going to do better. And hopefully we're going to offset that. Now, I've seen those labs be really high. I've seen them in 1,000. I've seen them higher than they can. And I know there's always a story about someone who gets put on a magical supplement or stops eating gluten and their levels just drop to nothing. And I love those stories. I've had them too. But I want to also give you permission that my patients have also not done that and have had high antibodies for a gazillion years, even though we're doing everything else. It's a process and the immune system is super complicated. And so I just want you to be okay. Not that we're not looking for other answers, but just know you're not alone if everyone else's thyroid is still struggling to get those antibodies down when they're doing the best treatment plans. For some people, it's years. It's not just fast. I love it when it is, but it's not always. Britton, you might have to cut us off, Britton, because I have a feeling we might be here all day and I'm happy to keep going. But I just want you to know.
Yeah, let's do a few more questions. Let's go for 2 more minutes. I just love that you're helping educate our practitioners and that's what we're here for. So I don't mind going a little longer.
Okay. All right. I don't want to just.
Yeah, no, I appreciate it. Thank you,
Yeah. If someone has high antibodies and thyroglobulins, should you do imaging? That's a great question. I think we probably just should. I don't always, but if they have both of those antibodies, it's probably not a bad idea to just get a marker. I think that can be just a cover your butt move, just get that ultrasound and just see how that goes, just to have a baseline. I have a question here about the timing of supplementation, and I think this is a great one. Because T4 has a very long half-life. Technically, you could give someone a whole week's worth of T4 once a week. They do that for people who are on the streets, maybe where compliance is poor. That's what they've done. I cannot imagine as a thyroid patient that actually works particularly well, truthfully. But technically, you can. But the timing of day definitely makes a difference. And the question I got was, can you take your thyroid at night? And the answer is 100%. Now, if you're doing T4 and T3 at night, that T3 activity is going to be there at nighttime. And for some people, they're going to find that too stimulating. It may disrupt their sleep quality. It may give them heart palpitations, which they notice more because they're being quiet and the world is quiet. But they can do it at nighttime. Lots of people do prefer to do it at night. And for some people, that's the best time to get an empty stomach and a fast, kind of as close to fasting as they can, because they may have to take other medications first thing in the morning, or they're just really bad about remembering, but they'll remember at night every night. And that's the other thing I would just say for thyroid is I sometimes will see people who have like high labs, and I've had these in my own patient. I'll say, are you taking it regularly? And sometimes what I'll have is, yeah, no, I miss occasionally. If that's the case, if someone's like, yeah, maybe, retest the lab, make sure that they are taking it all the time and then retest it, especially if they're feeling good. Because I definitely have had people who think they're just missing it once in a while. But I had someone recently and her TSH came back as 8. And it turned out that, well, I guess her odd times of missing it were around the time or the week that we did our testing. And all we needed to do was that. And her levels were down at 1. Now, the difference is she felt fine on both of them because she really was getting her thyroid, but it made my labs look really bad. Question about someone asked in Europe having fights with only having one thyroid. It is super frustrating to only have one tool in your toolbox because binders and fillers are really a big thing. And they make a big difference for thyroid patients for sure. I wish that wasn't the case. You can have people chew things. You can have them do it with digestive enzymes, but it is a frustrating thing. And unfortunately, like I said, some of the generics are much more variable from pill to pill than they used to be, or that some patients will notice. You just might have to bump their dosages up sometimes. When do I think medications are the first line? So if you have someone where their TSH is over 5, that's 100%. Odds are you're not going to do particularly well with just thyroid support, supplement wise, or change in diet or other vitamins and minerals. I think the 2 to 3 range is 100%, depending on how the patient feels. That's 100% worth doing supplements with. I have seen them do very well. I've seen the people who have TSHs that are less than 2, and once again, T4s and T3s are normal, but TSHs that are less than 2, who have all the symptoms of low thyroid, they have done great with thyroid support, like iodine and tyrosine and selenium and all the other things we know to do. They've done great. I think the 3 to 5 range is really the trickier one. And I think it really depends on clinical symptoms. I have a lot of people that have taken years to get their TSH up to 2 or 3. You look back and it's 1.5, 2, 2.5, 2.7. So finally they cross this line and I see them. And in the meantime, they have every single symptom. A lot of times for those people, I will use thyroid medication, but I might also do those other things too, right? It doesn't have to be any or one or the other. It's just, I think when you start getting above certainly 5, but maybe even 4, those people, it's usually not a fast process. Those processes they are very slow and people definitely have a problem. Question of how do you treat the low pituitary? And if there's also low thyroid, you actually have to give thyroid hormones. Yeah. So we have lots more questions and I'm happy to look through these, Britton, and maybe you can help me and we can make sure that people can get answers for them. So I definitely want to do that. I think it just shows how interested everyone is about thyroid, how many questions we all have. And I did want to just share my last slide, which is just contact information, because we're here and we help Rupa patients. If you tested through Rupa, you can still call the lab and we're still really happy to help you out. So don't hesitate to do that. I've got a team that's great and we're happy to walk through all the reports. So thank you. Thanks for having me.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.